Hello, this is an ARDS study note. This note addresses elastance, compliance, stress, and strain of the lungs in acute respiratory distress syndrome. Changes in lung mechanics are one of the main pathophysiological features of ARDS. The most well-known change is the decrease in lung compliance. When mechanical ventilation is applied in this condition, ventilator-induced lung injury can be provoked, resulting in various critical consequences. A comprehensive understanding of lung mechanics in ARDS requires knowledge of compliance, elastance, and the modulus of elasticity, in addition to an appreciation of the concepts of stress and strain, their changes, and how all these elements are interrelated. Therefore, in this note, I will address elastance, compliance, stress, and strain in the ARDS lung. First, let's discuss elastance and compliance. Elastance is the resistance to change the shape when mechanical load applied, mathematically expressed as delta V over delta P. The two major determinants of the lung elastance are lung connective tissue and alveolar surface tension and surfactant. Collagen and elastin fibers are important components of lung connective tissue that determine elastance. The fibrous skeleton system composed of collagen and elastin consists of two components: the axial system, anchored to the hilum, which run along the branching airways down to the level of alveolar duct, and the peripheral system, anchored to the visceral pleura, which penetrates centripetally into the lung down to the alveoli. The two systems are linked at the alveolar level by the alveolar septal fibers. In a schematic representation of this fibrous skeleton system, elastin resembles a spring characterized by its low tensile strength, and collagen can be depicted as a string noted for its high tensile strength. If this fibrous skeleton is homogeneous, uniform force is applied to both the elastin and collagenous system during inspiration. However, when consolidation leads to heterogeneity in a lung region, thereby increasing its elastance, it can cause excessive strain on the adjacent fibrous structures during the breathing process. For patients with ARDS on mechanical ventilation, this could result in ventilator-induced lung injury. Next is alveolar surface tension. Normally, the inside of alveoli is covered with alveolar lining fluid. The cohesive force among liquid molecules in this fluid creates an inward force known as surface tension. If the fluid lining the alveoli is composed entirely of water, this would lead to a substantial increase in surface tension, causing the lung to become extremely non-compliant. This increased elastance would make ventilation with transpulmonary pressures in the physiologic range impossible. Surfactant plays a key role in reducing this high surface tension to allow normal ventilation. Surfactant molecules interpose themselves among water molecules, weakening their cohesion and thus decreasing surface tension to the level where ventilation with normal transpulmonary pressure is possible. If abnormalities occur in the two major determinants of elastance, lung connective tissue, and the surfactant that reduces alveolar surface tension, elastance increases, meaning increased lung stiffness. The reciprocal of elastance is compliance, which is ability to change the shape of the structure when mechanical load applied. Thus, decreased elastance increases compliance, and increased elastance decreases compliance. In ARDS, overall lung elastance increases due to alveolar edema, inflammation and infiltration, surfactant dysfunction, fibrosis, atelectasis, microthrombi formation, resulting in decreased compliance. The modulus of elasticity quantifies the degree of elastance, and an increase in elastance results in an increase in this modulus. The next topics are stress and strain. Physically, stress is the force applied to a material divided by the material's cross-sectional area. With force F and initial area as 0, Stress is F over 0. Strain is the deformation of material that results from an applied stress. If an object with initial length L0 undergoes a change in length delta L due to stress, then strain is delta L over L0. Let's explore the concepts of stress and strain in the context of a normal lung and ARDS. For inspiration, the lungs within the thoracic cavity must expand, driven by transpulmonary pressure, which is the difference between alveolar and pleural pressures. The stress generated in the lung during inspiration is the force per unit area, representing the change in transpulmonary pressure. This change causes the lungs to expand or increase in volume, resulting in inspiration. In this case, L0 in the lungs is the volume after expiration of tidal volume. The resting lung volume, also known as functional residual capacity, FRC. Delta L is the volume of expansion caused by air due to the change in transpulmonary pressure, that is, the tidal volume, which we call delta V. Therefore, the strain exerted on the lung, or volumetric strain, is delta L over L0, or delta V over FRC. If delta V, meaning the tidal volume, increases, then the volumetric strain of the lungs also increases. In a condition with normal tidal volume, if the functional residual capacity decreases due to pathological reasons, then the volumetric strain in the lungs increases as well. In ARDS, the functional residual capacity is reduced due to factors such as alveolar collapse, alveolar edema, decreased lung compliance, pleural effusion, the supine position, and abdominal distension, leading to an increase in the volumetric strain of the lungs. When high tidal volumes are applied to ARDS lungs with decreased FRC, delta V increases, leading to an even higher increase in volumetric strain. The relationship between stress and strain is directly influenced by elastance. Stress is the result of multiplying strain by the modulus of elasticity, as represented in the following formula. As explained earlier, due to multiple causes in an ARDS lung, there is an increase in both volumetric strain and elasticity, which in turn leads to an increased stress associated with ventilation. Consequently, mechanical ventilation can result in ventilator-induced lung injury, which necessitates an understanding of lung protective ventilation strategies' impact on strain. High PEEP, prone positioning, and recruitment maneuvers can increase the functional residual capacity of the ARDS lung, thereby reducing volumetric strain and overall lung stress. As showed previously, while high tidal volumes increase strain in the ARDS lung, applying low tidal volumes decreases delta V, thus reducing strain and overall stress. Therefore, lung protective ventilation strategies decrease strain in the ARDS lung, resulting in reduction of mechanical ventilation-induced stress. To summarize the aforementioned contents, in ARDS lungs, there is an increase in elastance and modulus of elasticity, and a decrease in compliance. This results in increased stress, which is the product of increased modulus of elasticity and strain. If strain increases due to decreased FRC or inappropriate mechanical ventilation strategies, stress increases, leading to ventilator-induced lung injury and its critical consequences. This is the study note about elastance, compliance, stress, and strain in the ARDS lung. Thanks for your listening.